All right, we're going to do Chapter 14 in Pharm, hematology drugs. We won't cover anything. We're going to cover clotting a little bit because it's in your slides, but clotting is something that you guys covered in med-surg before you went out. But you do have a fantastic diagram, and by the way, we're starting on slide 6. Of course, this is mainly going to be for the medications, okay? But I do want you to look at that blood coagulation concept map, that diagram at the top. It shows that's the cascade. It shows you how that cascade works. But what I want you to know about clotting in a nutshell, of course, that my body has certain, what I want to call it here, clotting factors. It has different factors in the blood that know exactly when to clot. All right, my blood, of course, has got to flow freely in order to get nutrients and oxygen to all my tissues and pick up waste, carry it back to the heart through the lungs, and get rid of that waste. All right, so we need it to flow freely, but there'll be times where my blood needs to clot to prevent me from bleeding out and dying. Okay, and that can happen in your blood vessels. It can happen from an outward injury. There's lots of ways. Okay, so what I want you also to know is that a lot of those clotting factors come from my liver. So if I have liver problems, then I'm going to have some problems clotting. All right, so I can even check my clotting factors via a blood test to let me know exactly how my liver is working. Good thing to stick in your mind. But when you're looking at the page 266, what I want you to take out from that is thrombin. All right, before you see thrombin, you can see that there's a formation of thromboplastin, which acts with prothrombin, which is found in the bloodstream, to make thrombin. All right. I'm not really worried about how it's made. What I want you to know is what thrombin is. It's just an enzyme, and then it works with fibrinogen, which is a protein found in your blood. Those two things come together to form fibrin. All right. So thrombin and fibrinogen come together to form fibrin. And fibrin, I want you to think of kind of like fibers of a quilt. All right. So fibrin comes together and makes like a net that traps blood cells in it. And when it traps those blood cells, then I end up with a clot. Now, you do have to have vitamin K present to be able to clot correctly. And that's why babies, when they're born, they don't really have those clotting factors yet. Everything's just starting to work. So liver's not working correctly just yet. So we give them vitamin K so they can clot correctly. So that's what I want you to take in a nutshell. All right. Thrombin combines with fibrinogen to make fibrin. Almost flipped you off. The fibrin makes a net that traps red blood cells. It traps the blood cells there at the injury. So that forms like a clot. And that keeps the blood from flowing out. All right. It forms a seal right there at the injury site. And also remember about the presence of vitamin K. Also want you to remember, of course, your platelets and your red blood cells. You have to have a good amount of those or you can't clot. Okay, so if my platelets are very low, then I won't be able to clot as well. I know this is all just review, but just hang in there. Also remember about the vitamin K. We said that already. Okay. I want you to make sure that you know what a thrombi is. Thrombus is something that is stationary. And then we have a emboli, which is a moving clot. When it breaks loose and it moves. Very important to know. All right, now we can go to the next slide. What we're really here for, anticoagulants. They're drugs that interfere with one or more steps in the blood clotting process. All right, for some reason, these people are overproducing clots. So they need to stop that process so it's not clotting as much. I mean, I need to clot some, but if any of you have ever taken care of anybody on a blood thinner, what we call a blood thinner, all right, okay, I say blood thinner, all right, we're not actually thinning it out, okay, we're just keeping it from clotting as much as it was. Sometimes those people are very, very hard to stop bleeding, and that's why for most of your anticoagulants, or at least the ones that we normally take for severe problems, you have to get blood tests to make sure that those medications are at the right amount in the blood. And one of those drugs would be Coumadin, warfarin, same drug. We'll talk about that one in a minute. All right, it says they cannot dissolve, form clots. Very important to remember. They can only keep those clots from getting bigger and forming more. It even says blood thinners in here with air quotes, but they don't actually thin the blood. We're just keeping it from clotting. Very important to remember. All right, so there's a few ways that we're going to keep those. Memory jogger at the bottom shows you that we have 4 classes of anticoagulants. They're platelet inhibitors, direct thrombin inhibitors, indirect thrombin inhibitors, and vitamin K. So we're going to discuss those. Okay, for your platelet inhibitors on the top of 267, we see that we've got aspirin, Plavix, and tiaciclid, which tiaciclid is, haven't seen that in a long time. We also have Pledol. What I want you to circle in your book there are the most important ones are aspirin and Plavix. Okay, I think they still use Pleadol some, but Plavix and aspirin are usually your biggest ones there. Aspirin, of course, you can buy over the counter. A lot of people who have had cardiac conditions like heart attacks or strokes are instructed to take an aspirin a day. Could be a baby aspirin at 81 milligrams all the way up to 325. These drugs use a variety of mechanisms to prevent platelets from sticking together, all right? So again, not thinning the blood. I'm just keeping those platelets from not sticking together. And remember, when I have platelets stick together in that net of fibrin, then I've got a clot. So when my platelets don't stick together, then I don't form a clot. So we're keeping those platelets from actually adhering to each other. Okay, we call that aggregation. So when you hear platelet aggregation, all that means our platelets are sticking together. The important things to remember about this group of drugs is that antacids interfere, and this is on your table on page 267. Antacids interfere with the antiplatelet drugs. So teach patients to take antiplatelet drugs 1 hour before or 2 hours after taking antacids. Okay. Avoid taking NSAIDs because NSAIDs can make you bleed as well. All right. Aspirin is usually classified as an NSAID as well. Aspirin has multiple uses. But if I'm already going to not clot as well, I don't want to take anything else. It's going to cause that to make it worse. Let's see here. This is for any anticoagulant. Teach patients the symptoms of bleeding and report any signs of abnormal bleeding. Obviously, if you can't get yourself to stop bleeding and it's a large amount of blood, you should go to the hospital. Teach patients to avoid foods and herbs that can interfere with antiplatelet drugs. And I think we might have a list of those on page 269, box 14.1. Foods that may interfere with anticoagulants are tomatoes, onions, dark leafy greens, and that's usually the ones we tell them to stay away from, broccoli, garlic, and bananas. All right. Also, herbs and supplements are there too that we want them to stay away from. Remember, I always want to know their herbs and supplements because those can interact with a lot of drugs, not just the anticoagulants. Let's see here. What else? Never stop taking them without talking to the provider. That would be with any drug. And avoid these antiplatelet drugs in the last trimester because they can be a problem with breastfeeding and they can also make you bleed at delivery. Side effects of the platelet inhibitors are the next slide. You're going to see that's bleeding and easy bruising. That will be for almost all of your anticoagulants. And remember, bruising is just the collection of blood under your skin anyway. Adverse effects, again, we have bruising. That would have to be quite a bit of bruising. But I have seen quite a bit of bruising. I've seen somebody's whole left side of their body, one giant bruise from a very mild fall, but their anticoagulants were at high dosage. So, bleeding gums. A lot of people have bleeding gums anyway, but they can make it worse. And excessive sudden bleeding will be side effects of platelet inhibitors. We talked about the food and drug interactions on the next slide. And let me skip back over here. Let me make sure that we're not skipping anything that we need to. Oh, you have a wonderful safety alert on page 269. Okay, for any patient who is taking anticoagulants, watch for early signs of bleeding. All right, fantastic safety alert. And I think we should be good and go on to nursing implications and patient teaching. For patient teaching, you don't really have an area on that. Well, for patient teaching, you really want them to understand what it looks like if they have excessive bleeding, or if they have, even if they have small cuts that won't stop bleeding for a very long time, they should report that because they might need to look at their levels, and they may need to change things around a little bit. Not really any levels to look for except for maybe just to check your normal clotting factors, check your PT, PTI, and R, those things that come from your liver, okay? So if I'm looking at the amount you're bleeding, I'm definitely going to look at your liver studies. I'm going to look at your prothrombin time and your activated prothrombin time. Definitely what I'm going to look for if I'm looking for any excessive bleeding. But here it just says, watch for abdominal pain and tenderness, vomiting or diarrhea, and you definitely want to see if there's any frank red blood or coffee ground blood coming from diarrhea or from vomiting. Frank bleeding just means it's bright red, it's a brand new blood, and then the coffee grounds are old blood. So if they're throwing up and it looks like one of those things, definitely to the emergency room, or if they're doing that from their bowels, the same. And if they have cold, clammy skin, that can be a sign that they have an internal bleed. All right, that makes them very jittery, They're losing their blood out into their abdomen or somewhere, so they get cold and clammy because there's no blood going to their extremities to warm them up. All right, your direct thrombin inhibitors. It says there's 5 categories, and you see them under here. Direct thrombin inhibitors bind to prothrombin and prevent its conversion into thrombin. So remember how we said over here that there was a couple thromboplastin and prothrombin made thrombin, and thrombin and fibrinogen together made fibrin. All right, so we're cutting off the thrombin. Thrombin never gets made here. All right, and thrombin was the important thing that we needed for the rest of the cascade. With these drugs, thrombin never gets made. All right, some of these drugs to remember are Eliquis, a very popular drug now. Pradaxin, Xarelto. Those are all popular because they do fantastic job at keeping those clotting factors down, but they don't have to have any blood tests like Coumadin does. For these drugs, you want to watch for any abnormal bleeding. That's for all of them. Any allergy you want to watch and teach your patients what allergies look like, wheezing, shortness of breath, so on and so forth. No aspirin or NSAIDs because those make you bleed more. And keep drugs in the original containers. That would be for any drug. Let me look under your direct and see if there's anything else we need to cover that's not in that. Action, we got that. Uses for direct thrombin inhibitors for a deep vein thrombosis. We can use that. Remember, these are not good. These drugs are also not going to get rid of the clot that we already have. They're just going to keep that clot from getting bigger or making more. I might give these drugs for people who have a history of AFib. Remember back in cardiac, if we have atrial fibrillation, then our atrium in our heart just quiver instead of pumping, and that causes a lot of clots. So people who have AFib might get a direct thrombin inhibitor. It does say in here uses that they're used a lot, like warfarin and Coumadin. As a matter of fact, they're people who don't want to have all those blood tests will take these instead of Coumadin or warfarin. They work pretty much the same way. So people with strokes, heart attacks, things of that matter. Adverse reactions are, of course, the heavy bleeding, the heavy bruising. Must teach the patients about the symptoms that they need to report immediately or go to the hospital. Do we need that drug interaction? Look at the drug interaction alert on 270. That's pretty important as well. All right. Our next... Well, actually, let's go to your slide. Your slide on slide 11 talks about direct thrombin inhibitors. It talks about heparin. It says coumarin, but that should be Coumadin. Remember, I didn't make these slides. They came from the book, people. Platelet aggregators and protease activated receptor agonists. And let me see if I can find those in the book. Oh, you did. They're right below that. They have heparin under indirect in the book. So that just goes to show you that even the people who write the book, even though it comes from it, they must not be the same people writing the slides. All right. We're going to skip slide 11. All right. Don't even pay attention to it. Go by what your book says. The next slide is direct thrombin inhibitors as well. The actions and uses. Slide 13 is the adverse reactions, and they're a little bit different for all of them. Now, we've already talked about the drugs, Eliquis, Pradaxin, Xarelto. Now we're going to look at the indirect thrombin inhibitors, although your slide keeps saying it's direct. Let me see if I can look at this slide real quick. I think they just messed up on the slides. I'm not sure. But your indirect thrombin inhibitors, these drugs work indirectly, preventing the conversion of prothrombin to thrombin by increasing the amount of active antithrombin. So we're not actually stopping the production of thrombin. We're using antithrombin so that we're not working directly on the thrombin itself. We're just doing it in a roundabout way. Okay? So you don't really have to remember that. Just remember that they're indirect, that it's not actually working directly on the thrombin, but it's using other mechanisms to keep the thrombin from becoming active. Now remember, if we have active thrombin, it can combine with fibrinogen to make the fibrin, and then we have that web that we can catch the clots. So we can make the clots from that web. All right, for indirect thrombin, we have heparin. Heparin is usually used usually for short term. It says we can give it IV, we can give it IM, or not IM, we can give it IV or subcutaneously. But it just really depends on what the problem is. Now, people who have a lot of clotting problems and they need heparin, if they've had a stroke, if they've had a recent heart attack, they've got a blood clot, they will go into the hospital and probably be on a heparin drip until they put them on Coumadin. And actually, they'll have them on Coumadin and a heparin at the same time. Okay, we're going to talk about Coumadin at some point in here. Oh, it's on the next page. All right, so if usually, here's how it goes. Say somebody had a blood clot, okay, and they come in, well, they're eventually going to need to be put on Coumadin. All right, Coumadin's what they'll go home with. Coumadin we'll talk about in a minute. We'll talk about all those little details with Coumadin. But while Coumadin is oral, it takes a little while for it to start working in the blood and a little while to get it correct levels. And while I'm doing that, I'm going to be on heparin at the same time because heparin is going to work a lot faster. Of course, it's sub-Q or IV, and so it's going to help me keep from making more clots, okay, or help me keep that one clot that I've got from getting bigger and bigger. So if I need something that's going to work super duper fast, all right, it's going to be heparin. It says the IV flow rate for continuous heparin infusion is ordered by the prescriber and is based on the activated partial prothrombin time, the APTT. And so monitor those results. Remember, if I'm looking at clotting, I'm going to be looking at an APTT, and for some medications also a prothrombin time, just a PT. And also an INR. Okay, so you might hear a PT INR, you might hear APTT. It just depends what the drug is and what they're looking for. But those are all labs that I'll be looking for clotting. Watch for signs of abnormal bleeding. Teach the patient how to do that as well. Monitor patients who are receiving heparin for wheezing, shortness of breath. That could be an allergy. Of course, it's going to be a heavy antiplatelet, or excuse me, an anticoagulant. So nothing else that's going to cause me to bleed heavily, like the NSAIDs. This one's very important, and you'll need to remember this for all of your life. Ensure that the heparin antidote, proadamine sulfate, is available, so it can be given quickly in case I overdose them on accident. Anytime that you see in these books that there is an antidote, you'll need to remember it. So for heparin is proadamine sulfate. Your next page, you've got vitamin K antagonist. Remember these two phrases. An agonist causes something to work, and an antagonist stops something from work. It stops a response. So a vitamin K antagonist is warfarin. Remember, vitamin K helps you clot. Warfarin works on vitamin K, and lowers the way that you produce vitamin K, so you're not clotting as much. So they actually reduce or prevent the formation of vitamin K. So for this, they need to avoid green leafy vegetables because those will be those are sort of like, it's not a complete antidote for it, but they will stop Coumadin from working. Okay, really avoid those dark leafy. Anything rich in vitamin K, these patients need to stay away from because it reverses the effects of the warfarin. Remember, warfarin and Coumadin are the same thing. Monitor the INR. I want you to circle that because remember I said sometimes we'll do an INR to look at clotting factors, and this is the medication that we'll look at is an INR. Okay. Remind patients to keep appointments for INR lab sticks because that's going to tell us if there's enough Coumadin in the system or not enough, if there's too much or not enough, or if it's just right. And your doctor will have to adjust the dosage of Coumadin by what your lab results say. So you need to have your INRs done when the doctor says to. Stress the importance of not taking those NSAIDs because they make you bleed more. Ensure that warfarin antidote vitamin K is available so it can be given quickly in the case of an overdose. So you have to remember that one. Vitamin K is the antidote for warfarin. People of childbearing age, women of childbearing age who are taking warfarin need to avoid pregnancy and make sure you know their herbal drugs and supplements. Let's see what else we got here. Fibrinolytic drugs. If we can find those. We're just going to go ahead and, okay. So on page 272, before we get there, there's a top tip for safety. When injecting subcutaneous heparin, do not pull back on the syringe to aspirate. This can cause some tissue problems. Do not massage the injection site. Very important for you to remember, never to massage the injection site. Now, if we go back over to heparin on page 267, you're also going to see a drug that you're probably familiar with. It's low molecular weight heparin, and that's Lovenox. The other ones, Atrixia, Fragmin, and Inohep. Not familiar with those. Lovenox is big in our area. But these are low molecular weight heparins. All right. So Lovenox, of course, you know, to give the bubble goes stays in there. It goes last because that seals the wound. You don't want to rub that as well. It's giving the same way, sort of. But Lovenox comes pre-packaged for you. And I'm sure while you were out in clinicals, you gave plenty of Lovenox. All right. Now we can go over to... where are we at? Another safety drug alert, administration alert on 271, I want you to put a star beside, is roll the heparin bottle between your hands rather than shaking it. I can't think of a lot of medications unless it's a suspension that we swish or we swallow that we shake up. Everything else should be rolled in your hands. The top tip for safety on 272 we already talked about, plus the one at the bottom. Teach women of childbearing age. Okay, breastfeeding, the heparin antidote, all those things are what we've already gone over, but I want you to read them again. And then I think we can go over to page 275, or 274, excuse me. Lifespan considerations, I want you to look at that. Older adults may be more sensitive to the effects of anticoagulants. A lower maintenance dose is usually recommended for older adult patients along with very close supervision and monitoring. Start low and go slow. That's every medication for an older adult. This particularly true for patients who receive warfarin and may be vitamin K deficient because of low intake of green leafy vegetables. Pay attention to that. Make sure you look at your memory jogger. We've already talked about it, but heparin and warfarin can be taken together at the same time, whereas most other anticoagulants do not. So that's why you see a lot of people coming home on Coumadin and warfarin. It's old, tried and true, and I can use heparin in that acute phase in the hospital. Also, before we get to fibrinolytic drugs, which I guess we'll start on the next video because I got to stop and give you guys a test. You want to look at that top tips for clinical cues. Teach patients to tell their dentist and their healthcare provider that they're on anticoagulant, so they're, you know, they know about the bleeding. They probably want them to maybe stop it a day before. Just depends. And that talks about it on the next slide. And then drugs such as Plavix used after a stent placement should never be abruptly stopped without consultation. I'm going to say nothing should be abruptly stopped unless you're having an allergy to it. All right, but when we come back, we're going to do fibrinolytics.